Hello there. I am Jen Cullen, manager of the dental sales business at TechScan, and I'd like to start by thanking you for joining this session this evening for most of you. Today's session is about utilizing digital occlusal technology to prevent occlusal force complications. Before we begin, I have a couple of brief comments. Please feel free to ask questions. I'm sure you're all familiar with Zoom by now. You can type your questions into the Q&A box, and we will attempt to answer all questions at the end of the session. If we do not get the opportunity to answer your question, we'll contact you directly after the session. Also, if you experience any audio issues, you can dial in directly instead of using your computer audio. Phone numbers will be listed in your webinar invitation. Now, I would like to introduce you to Dr. Robert Kerstein. Dr. Kerstein received his DMD degree in 1983 and his prosthodontic certificate in 1985, both from Tufts University. From 1985 to 1998, he maintained an active appointment at Tufts as clinical professor teaching fixed and removable prosthodontics. Over the past 37 years, Dr. Kerstein has published many original research studies using all versions of the T-scan that has led him to becoming the leading authority and researcher in the field of computerized occlusal analysis. His findings have been published in journals around the world. And additionally, Dr. Kerstein has edited a 3-volume research handbook about all the known applications of the T-scan occlusal analysis technology. Dr. Kerstein is a true pioneer and academic science advocate for digital occlusal technology. So thank you so much for being here, Dr. Kerstein.
It's my pleasure to be here, and thank you for that very nice introduction. I'm very honored to present to all of you today to discuss the T-scan 10 technology and how it can help you prevent common prosthetic complications that frequently occur in daily dental practice, really after newly installed dentistry has been placed. And I can speak to this because in my 37 years of using the T-scan technology, I was sought out by patients who had dentistry installed and struggled to adapt. And the interesting thing about that was that it wasn't always full mouth rehabilitation. It was 3 fillings, 2 crowns, a tooth was extracted, or they finished orthodontics and they were developing symptoms very soon after their occlusion had changed. And with the T-scan, I was able to readily diagnose their problem and often treat them in 1 or 2 appointments when they had had many appointments that didn't resolve their problem, with many doctors trying to help them. And the difference maker was really being able to measure their occlusion. And that's really the great value of using the T-scan technology, is that it measures force and timing occlusal metrics that can't be captured in any other way. So I'm very excited today to share this information with you, and hopefully it will help you understand how utilizing measurement technology that provides you with data and metrics to be able to understand the occlusion can help you prevent and deal with common complications that follow newly installed prosthetic dentistry. Let me remove my video. So thank you for your attendance, and I'll look forward to answering any questions you have at the end of the presentation. A little bit more about me. Jen was very nice to introduce me. I have published over 83 peer-reviewed articles on computerized occlusal analysis, and she did mention the 3-volume T-scan research handbook, which does discuss all the clinical applications, research-based clinical applications of the T-scan technology and associated technologies that the T-scan works with. And I was very fortunate to work with 20 experts from around the world who contributed their T-scan expertise in fields like posture and prosthodontics and implant dentistry and orthodontics to compile this really detailed 3-volume textbook on all the applications of measured digital occlusion. I am a consultant for TechScan, but I do not receive any compensation for sales of any TechScan products. And my role is education, research, and training. And the opinions expressed today are those of my opinions, and not those of TechScan. So we are in the digital era of dentistry. And of course, prosthodontics, my specialty, has become highly modernized. We have scanners, and we have planning software, and we have CBCT, and we have virtual articulation and virtual restorative planning, and also virtual restoration imaging. So it's a fantastic era that we're in. And the operatory now surrounds the dentist with many computer-based tools, with lasers and microscopes and computer screens in every corner. And this is all in the hopes of providing incredibly high levels of precision, really surrounding what has become known as the digital workflow. And many of you are practicing in this newly evolved prosthodontic method, this digital workflow. But it's interesting, despite the digital workflow, implant restorative problems are increasing. And this is really due to occlusal force management. And excessive occlusal forces, they fracture implants, they fracture restorations, chipping of porcelain is very common, broken parts is very common, peri-implant tissue disease is very common. And the thing that we're really talking about today, difficult patient occlusal adaptation, is the most common thing that I saw, as I mentioned in the introduction. And it really is due to the use of non-digital occlusal indicators during case insertions. And the reason for that is simply that traditional occlusal indicators do not measure occlusal metrics. They do not provide the information that really helps one control these force-related problems. And so we're seeing studies like this in the literature, this 2018 publication where 114 full arch immediately loaded implant restorations, 50% of them broke, and another 26 had more than one complication. And of course, if you've had one of these restorations break and you repair it, unless the occlusal problem that broke it is really addressed, it's going to break again. And so repetitive fracture rates are actually very high as well. This is an interesting systematic review that looked at fracture rates, chipping of ceramic materials, between zirconia ceramic restorations and metal ceramic restorations supported by implants. And what was interesting is there were nearly 800 metal ceramic implant supported fixed partial dentures that only fractured 11% of the time, or a total of 68. And yet 5 times less, 1/5 the amount of zirconia ceramic restorations had a 50% fracture rate, which is very comparable to the previous study. And of course, we're going to zirconia ceramic, hoping that it will actually, be harder. It is harder and stronger in theory, but its fracture rate is much higher. And of course, this is because the occlusal management at insertion is not as well controlled as we need it to be. But the T-scan technology offers you a solution to these common occlusal complications. And the beauty of it is that you take the data directly from the patient. It's recorded instantaneously, and you have a lot of tools that help you understand whether the occlusion is good, not good, great, poor, and those tools help you make intelligent decisions about how to improve your outcomes. And I'm going to illustrate some of those tools in the examples that I show you within the program. And these tools make a huge difference because they're all based in dealing with force levels and timing problems. So what is the T-scan? For those of you who don't have not heard of it or have not seen it yet, it's comprised of 3 elements. The high definition Nova sensor, which is capable of measuring 256 levels of force. It's also capable of being crushed 20 to 24 times and give you reproducible occlusal force information. It's used in many different applications throughout the world in different forms, and it's a very accurate and reproducible entity. It transfers digital force and timing information to the Novus handle, which is ergonomically designed and has a number of buttons that allow you to work closely with the patient. You can play the T-scan data forwards and backwards with these numbers. You can record, with these buttons. You can record directly from the handle. And then that information is transferred to companion software, which has all these tools that allow you to analyze in 2 dimensions and 3 dimensions in a dynamic movie format, the changing forces of occlusion within the patient's dental arches. And so the 3 elements work together to provide you with instantaneous information that's taken directly from the patient about the quality of their occlusion. The T-scan has been shown in studies to be very reproducible. That's what you're seeing here on the left. This is a study of the Novus HD T-scan sensor, which shows you 6 different occlusal contacts in a set of dental casts being repeatedly crushed. And notice that there are different force levels. That's what the different colors are, and how linear these forces are being reproduced intercuspation after intercuspation. So that means to you as a user, you can get repeated, accurate, multiple different occlusal force levels from your patient's teeth time and time again. And you see the T-scan sensor sits between the teeth. This is the only way you can capture this information. Scanning technology doesn't capture this information. Articulated casts do not capture this information. Virtual articulation doesn't capture this information. And that's because we're really taking pictures of teeth instead of measuring the forces between the teeth. And then what you receive is a digital output of transitory changes in occlusal forces. And you get to see the timing. For example, here, I haven't played the whole video, and you can see there's early anterior force excess, then there's posterior left force excess. And if I continue on, there's 3 or 4 very high force contacts, 2 of them on implants that have generated an implant warning. And so this continuum can be stopped and started at any time to be able to play forward and backwards, and gives you very detailed information about where the problems in the occlusion lie. And you also have, with T-scan 10, with the Nova system, the ability to incorporate an STL file into your digital display, which is a wonderful merging of modern day occlusal technology. And this allows you to know exactly where on the teeth are the problem contacts. For example, you can see on the T-scan digital arch, this high force, for example, on the left, that is on the marginal ridge between the 2.5 and the 2.6. And this implant overload is really on the palatal cusp. This one is on the palatal cusp. And this early central incisor that you saw rise there, I'll play that again. Right there, that early central incisor force is in the middle of the 2.1. And this is the kind of control you have over the data, which allows you to make very intelligent decisions about how to address the problem contacts in someone's occlusion. And what this really does for you, the T-scan, it provides you additional information that clarifies for you the true problem contacts. And this is one of the best examples of how the T-scan helps you chairside. This patient has 3 large paper marks on the first molar with very healthy tooth structure under those paper marks. Here we have exposed dentin with paper marks really at the periphery of the exposed dentin. And I'm sure many of you have seen when you try to mark exposed dentin, nothing really marks there. Well, there's a very good reason for that, which I'll talk about in a second. But notice that these 3 large marks, the tooth structure is extremely healthy. And here you have exposed dentin. The counterpart second molar also has exposed dentin, and there are no paper marks there, but there are some peripheral to the extreme loss of tooth structure. And then again, you have 3 large paper marks and extremely healthy tooth structure. So what's really going on here? Well, it's very unclear in traditional occlusal indicator methodology, but the T-scan clarifies for you extremely well. There's a very high force overload. The second molars are taking 50% of the total force of the occlusion. And you can see the center of force, if I play it again, it's tied directly to the second molar. The center of force is a force summation vector that moves around the arch and travels towards high force and away from low force. And you see it's drawn right to this area. So this is destroying the enamel. And yet nearby, the next tooth up, the first molar, is very low force. And this is the problem you face every day. How do you know how to interpret this information? And this just illustrates how misleading the paper marks are. Look, the tooth structure is perfectly healthy where there are 3 large marks. And the exposed dentin doesn't mark because the forces are so great that the enamel is destroyed. So think about it logically. How can the paper and the ink survive if the enamel can't survive? Right? That's really what's going on. The paper gets destroyed, the ink gets destroyed and pushed to the periphery. That's why you never see any ink on exposed dentin. It's not because, quote, it doesn't mark. It's because the forces are so great that the enamel has been destroyed, and that's why the paper can't survive. So the T-scan really explains for you which problem contacts you should treat and which ones you should leave alone. And this is really the most important element that really helps you chairside, because instead of subjectively interpreting which is the problem context, you know which is the problem context, and then you treat the appropriate context rather than interpreting this by yourself and saying, well, I think it's this contact because it's dark and big, when that's actually low force, which happens a lot. This paper showed, looking at 600 paper marks, that a large paper mark was only forceful 14% of the time, which means that 86% of the time when you're looking at large marks, they're not going to be forceful. And if that's your guide, if you're practicing with the idea that size is going to tell you the force, you'll be wrong 86% of the time. And that directly leads to choosing the wrong contact, which often leads directly to setting up an occlusal complication. So because of the T-scan technology, the science of occlusion has evolved. And recently, this systematic review, which was published in the European Journal of Prosthodontics and Restorative Dentistry, studied or looked at the literature of the accuracy, reliability, and the clinical implications of static occlusal indicators, which would be traditional occlusal indicators, wax, silicone, imprints, articulating paper, shim stock, foil, and compared those to quantifiable occlusal indicators, which really is the T-scan system. And what they found after breaking down the 231 papers into the ones that really were worth reviewing, were scientifically valid, that little evidence supports the use of static occlusal indicators because they are subjectively used. Subjectively used means we look at them and we try to decide, well, I think it's this contact, I think it's that contact, and that leads to a lot of issues, whereas much scientific evidence supports the use of T-scan because it measures relative occlusal forces and timing objectively, accurately, and repeatedly. And this is really important to your day-to-day practice of occlusion, because objectivity, accuracy, and repeatability allows you to make very intelligent decisions about the patient's occlusion diagnostically and during treatment. So because occlusal technology has evolved occlusal science, because the T-scan, this research that's been going on for the last 38 years around the T-scan has evolved occlusal science, we can now offer our patients improved and predictable occlusal outcomes. So by properly applying T-scan data, and of course, one has to learn how to use the T-scan and how to properly apply it, but there's many resources available to teach you the value of how to properly employ it. You can improve patient occlusal acceptance to new restorative procedures. As I said at the beginning, this was the one thing that I saw more than anything else that people sought me out because I was known for using the T-scan. They were surprised that after 1 or 2 appointments that I was able to resolve their problem when they had been to many dentists, very high quality dentists who didn't have the technology and were unable to resolve their issues. And I'm going to show you some of those real life examples in the presentation. And because you can improve patient occlusal acceptance, that lessens the post-insertion bite adjustment visits that plague a practice where, the same patient keeps coming back saying, my bite doesn't feel right. My temporary felt good, but ever since you put in the new crowns, I can't chew, my teeth hurt. This is a problem that plagues dental practice and can happen in any case because of these traditional occlusal indicators. They're not objectively used, they're subjectively used, and that subjectivity leads to problems. And because you're dealing with T-scan, you're dealing with force and timing metrics, you prevent breakage and fracture of teeth and implant components. You lessen that problem dramatically in your day-to-day practice. And you minimize occlusal force overload sequelae, such as peri-implantitis, screw loosenings, fracture and breakage, things that we're commonly seeing where these complication rates are going up in implant dentistry compared to conventional prosthodontics because of system rigidity. So these are all the things that will help your day-to-day practice work more smoothly if you have T-scan to implement into your occlusal practice. So in simple terms, if you want to improve your prosthetic occlusal outcomes and markedly lessen your daily occlusal complications like fractured implants, fractured restorations, which are implant supported, and also chipping of porcelain on conventional crowns and patients complaining about sore teeth, you will need to evolve occlusally as well and adopt what a T-scan based treatment approach means to your patients, but also what it means to your practice. So let's talk about complications. Do you ever come across patients stating after they get new dentistry, my bite just doesn't feel right? And you look, you see, you mark, you try to figure out what's wrong, but you can't really know what the true problem is. Or patients like this one who have beautiful teeth and they're in pain and there's nothing wrong with their teeth. They have no fillings, they have no missing teeth, they have no poor alignment, and yet they're having headaches and jaw pain and they're struggling to chew, but we can't identify the true cause. Or this problem, the most common problem, repeat bite adjustment visits after inserting new crowns or new implant restorations. And as I said, this is the common plague of dental practice. Well, what's interesting about this is I had these same struggles with my cases when I was a prosthodontic resident. I was a first-year student, and I would put in my 3 new crowns on one of my patients, and they would readily adapt to those crowns. And then I would put 4 new crowns in another patient, and they wouldn't readily adapt. And of course, I couldn't understand what the difference was. I was doing virtually the same thing, and I think you would all relate to that because you generally have the same protocol for installing cases, patient to patient. And every now and then I'd hear a story, I'd be in the lab late at night waxing up or making porcelain crowns. And I was a first year student, and the second year student, there'd be one saying something like, I can't finish my full mouth rehabilitation, and telling his own classmate, my huge case keeps coming back and I can't get her comfortable, and the faculty's been in to help me, and they can't seem to figure out what's wrong either, and I'm not going to be able to graduate if I don't finish her case. And that's just the nature of these occlusal complications. They prolong these cases. So I decided to reconsider my approach and use data, because with data, it's very easy to see what's wrong. Right? It doesn't take, all you have to do is look at one good scan and play it, and look carefully, stop and see the fast rising forces, and the T-scan maps them out for you. This is tooth number 6. This is tooth number 15, palatal cusp. And you can see there are implant warnings. We'll go further into this movie. And then there's high force in 3 or 4 other places. It's very visible what's really wrong here. And then you just make those corrections based on the data set. And it isn't only the highest forces, it's also the timing. As I said, contacts like this one, which rise too fast, may not reach full force. You see, that one doesn't get as high as the others. It actually lessens over time. And that happens in fractions of seconds, which you would never be able to see. This movie itself, what you're looking at is maybe 0.3 of a second, right? But by using this data, I was able to get faster patient adaptation. I was able to get improved patient outcomes, less breakage. And so I began studying the T-scan technology and applying it to all kinds of clinical scenarios. And the value of it is really what happens when you don't have the T-scan? What are those possibilities when you don't use data? Something like this.
I had a lot of dental treatment done about 2 years ago. I had some crowns and some overlays and inlays done on all quadrants of my teeth. And after that, my bite was just completely off. And I had a lot of pain in biting, a lot of heat and cold sensitivity, particularly cold sensitivity, a lot of difficulty relaxing my teeth and jaws, even just when I was not chewing, just in a regular, holding pattern. And agonized basically for 2 years, wondering what I could do. And I happened to come across Dr. Kerstein's information on the web and knew I had to get in here. And 1 week post-treatment, I feel as though my jaw has completely relaxed and has been allowed to come forward more. I was particularly feeling a lot of sensitivity on the left side, but it feels so much better now. Cold sensitivity has started to decrease. I'm much better able to chew harder foods, things like broccoli or carrots or things that have more snap to them, nuts in particular, where before I really had to baby them and practically suck on them. Now I can actually bite on them, which is just amazing to me. So I feel there's just been a tremendous improvement.
So what treatments did you have after the crowns were made? You had the dentistry done. What did you try to do for help?
So actually, I went back to the original dentist several times, and he would use the blue tapes and just try to grind down the teeth just from looking at the regular blue tapes. Like I said, I probably went back to him about 4 times, and I was classified as someone who had an extremely sensitive bite, which just annoyed me because I knew there was a lot more going on in my mouth than that statement. I felt as though I was sort of being dismissed a little bit. And then I tried 2 other dentists who were very sweet and tried to help me, but I just could not get the relief that I now feel from this procedure.
And did they use carbon paper
Yep,
only?
carbon paper only. There's no other.
So they didn't use computerized bite
No
analysis?
computerized bite analysis, no.
So that's a typical story of a patient. I just want to point out she's wearing EMG leads. One of the great things the T-scan does is it synchronizes with electromyography software, which is really an incredible combination. But the treatment that she received was based in the T-scan. The occlusal treatment was rendered by the T-scan, and her muscles were measured before and after treatment as part of her therapy. So the question becomes, why do these post-insertion occlusal complications occur? Well, despite our best efforts in the digital workflow to comprehensively examine and treatment plan and collaborate with all the experts in different fields and fabricating really precise surgical guides and designing custom abutments and making beautiful restorations, and the laboratory fabricating everything, within computer technology these days, it's amazing, really. And the beauty of the restorations is increasing. We get to the end of this entire digital process, and then we go analog, and we use a material that doesn't provide us with information that allows us to control the outcomes with high precision. Now, some of you may believe you understand what this means, but studies actually show dentists have a very hard time choosing the right contacts. Actually, there are 3 studies in the literature involving about 700 dentists that show dentists choose the incorrect contacts about 87 to 95% of the time. And you may have experienced this. In simple terms, an example would be we put in a crown and the patient says it's high, and we go and mark it and we grind the contact we think it is, and the patient says, no, Dr. Kerstein, it's still high. So what did I do? I chose the wrong contact. I didn't improve it, right? If you've had that experience, you've been choosing the wrong contacts. Now magnify that out to 14 units of a hybrid restoration or 28 units of crown and bridge, and that process becomes extremely difficult to control. And so the question becomes, what can you see in this material? Well, a better question is actually, what can't you see? Because that's the real problem. What's missing, the information that's missing. So here's some of the things that are missing. Is this contact forceful? Am I hitting too hard here? And the reality is the size of the mark has nothing to do with the applied force. And actually, the smaller the mark, the greater the pressure. That's why when you want to chop ice off a block, the ice pick has a very small, sharp point. It's not a flat surface, because big flat surfaces don't apply a lot of pressure. but small contacts can be extremely pressurized. And so there's no way to know if this small contact is high force or low force, and there's no way to know if this big contact is high force or low force. So there's a lot of missing information with respect to the amount of pressure that's being applied based on the contact sizes. If there was an implant under this overdenture, when is it loading? If it's loading early, that's problematic. It's going to take a lot of pressure and a lot of forces will be increased. The pressure will increase because of the rigidity of where the implant is. But again, there's no way to know that by looking at this information. Now here you have a contact that could be high force, could be moderate force, could be low force. And of course, we see there's ink missing from the middle. So maybe it is high force, but the ink may be missing from the middle also because it didn't stick to the tooth, right? So it's on the opposing cusp. But there's no way to know what the force level is, regardless of whether there's ink missing. It could be the same level of force as this contact, but again, no way to know. And how much pressure is this contact taking? It's not really marking well. It could be taking high force. It could be taking low force. It could be a good contact, but there again is no way to know. Whereas the T-scan answers those questions for you in one good recording, right? So the answers are there. It's just not possible to see them in a material like this. And of course, this is the most common way we deliver our cases. So there are three things you miss when using articulating paper: force levels, pressure mapping, and timing, all of which are key factors that help control destructive forces. But if they're not improved at, if they're not managed at case delivery, they'll prolong the case installation and they'll induce complications. And this is what is information that really helps, what is why the T-scan helps you, because it measures all of those things for you in one good recording. And here's an example of that. You see this rapidly rising force on this canine, a collected area of high force in the second molar area, a late rising overload on the first molar on the right side. And so these are areas that are problematic. This is a moderate force level that also could be minorly problematic, but it's all mapped out for you. And there's force percentage per tooth. There's a very nice feature I told you about earlier, the center of force. It really shows you the concentration of the total force and how it moves through the arch. And you see here the left side controls that. This force summation stays on the left. And then you have balance. This is 61 to 38, right? That's not good balance. And so as a result, this case is very left-sided with a high force rising on tooth number 11 that's really too fast. And there's non-simultaneity. And all of that was recorded in one movie, right? So you have a lot of metrics to work with, a lot of things to help you understand how to improve the outcome. Now, you may say to yourself, well, I have a scanner and I have planning software, so I don't need the T-scan. But that's actually not true, because scanning and planning is really, all it really is photographs of teeth. It's not interface pressures. And the planning software that allows you to design contacts is a geometric approximation of what the contacts will be. It's kind of like if I wax up a crown and make a temporary from that wax up and put it in the mouth, even though I waxed up ideal contacts, it doesn't mean they're ideal in the mouth. And you've all seen that. I mean, how many times have you put in a provisional and you had to adjust the bite, right? Even though the lab made a beautiful provisional for you. So the question becomes, what do you do with this information? How does this help you, right? In the end, when you have to deliver the case at prosthetic insert, well, this isn't really going to help you. There's nothing here that tells you which contacts are too forceful, which contacts are light force, which ones are hitting too early. And of course, when you take the real data from the patient, the T-scan data, you find out that tooth number 15 or the tooth 7 is actually where the forces are concentrated, and maybe a little bit on tooth number 1-6, right? And that is where you need to go to balance this bite. This information won't help you with that. Now, that's not the only scanning system. So let's look at another scanning system. First, we'll make a comparison between T-scan and articulating paper in this case. So here you have the large marks on the premolars, and you see that there's extremely high force on the number 8. But, oh, there's no paper mark on the number 8, right? So this medium won't help you isolate the high force. That's the high force on the 8. And the paper marks They show you large paper marks, but that's actually low force. So what about the other scanning technology? So this is interesting. There's a lot of red annotation here. Red in this scanning software, scanning program, excuse me, means solid contact. So there's solid contact, but solid contact doesn't mean high force. It means there's good occlusal interdigitation. The only place there's high force is on the 8, and it isn't this area. It's actually a very small area, right? That's where the high force is, in the middle of the solid contact. So again, at case insert, this information doesn't help you. It can help you maybe plan your restoration to have good contact, but it's not going to help you control the forces at delivery. That's where you need the T-scan technology. Because when you deliver a case like this, a full arch reconstruction, and you find out that it's 72% to 28% with the T-scan, would you send the patient home? If you knew it was 72 to 28, would you send the patient home with that result, even though there's contact bilaterally? Well, not when you see the T-scan data. It's very clear the left side is way too early. The right side barely doesn't make contact except in one place on the 4-6. And in order to deal with this, it becomes very clear where the problems are. The distal lingual cusp of the 3-7, the mesial lingual cusp of the 3-7, and the buccal cusp of the 3-5. And that's how you begin to improve the outcome. And I'll show you a case of how you sequentially improve the outcome a little later in the presentation. But this is the problem you face every day. Which contacts are too early? Which ones are too forceful? Where are they in the arch? And of course, using an STL file simplifies that for you. This is one of, as I said, one of the great T-scan features is the merging of scanning STL files with T-scan data. So it simplifies where you locate the contacts. Because the reality of occlusion is that how things look visually is not how they truly are. And you'll see that in a number of ways in this presentation. This is the first example of that. This patient was sent back to me from the orthodontist. The orthodontist wanted to deband the patient. So we use the T-scan to evaluate orthodontic treatment stages, and if the orthodontic end result is ready to be debanded. And other than, if you look at this carefully, other than this gap here between this premolar and this premolar, which I think is being held up by this bracket, the case looks like it's well interdigitated, and the orthodontist believes he's finished. But you put the T-scan in there and you find out again that it's 73% left, 27% right, with all the force concentrated in the posterior left and very little contact through the anterior and not so much contact on the right. The right side has to be better interdigitated. The left side has to be less interdigitated, and the front teeth have to strike better. And so the case is not ready to be debanded. And this is the value of measuring the occlusion, because you cannot tell those things from looking at the visual contacts. So how do we use T-scan data to help us at case insertion? Well, you sequentially use it by making recordings and then following those recordings with T-scan guided adjustments of the rapidly rising high forces and moderate forces and the time early contacts. And in the same appointment, you sequentially make another recording and you do another round of adjusting based on the T-scan. And you do this until you have a low force, widely uniform profile created where the center of force is in the middle of all the restorative units. And once you complete that process, you can then go in and do excursive corrections, because the T-scan records dynamically. You can record biting down multiple times. You can record biting down, holding, and sliding left. You can clench and grind on the sensor. You can chew on the sensor. You can record whatever you want. Generally, we would balance the prosthesis first, and then we would improve the excursions to follow. So what you do with the data is you map it to the patient's teeth. So this is an orthodontic patient who finished braces. He's 15 years old. And within a month or two of finishing braces, he developed TMD symptoms. And I saw him about 5 months later after he had had a few appliances made, and he wasn't getting any better. And this is his data. And there's an extreme concentration of force on the posterior left and it's, it's basically in this area. So you take this information and map it to this information, and that's done like this. So I'm going to just use a small section of this to illustrate how we do this. So first you set the T-scan arch up to match the patient. So you size the T-scan arch to match the patient. You can actually measure each tooth if you want, or again, you can use an STL file if you have one. Then if we look at the 2-6 mesial, there is a large mark there, which actually corresponds to a very high force. Then if we move a little distal and slightly labial, we have the next contact, which is moderate force. And you see that contact here. And then if we move a little more distal and palatally, we have the next contact, which is this contact on the incline. And that's a fairly high force. And this is how you determine which contacts are problematic and which ones are not. And again, if you believe in your head, you can read the paper marks. Let's look at the 2-5 mesial contact. It's actually very low force. It's this contact right here. And so this is a problem you face every day, how to map these contacts. And what this means to you prosthetically is, instead of trying to interpret these marks subjectively, like what does all of this mean, you use force and timing data sets to guide which contacts you're going to adjust. And this is a really good example of how, whoops, let me go back, how misleading the paper marks can be. So here you have a very large dark mark, and it's actually a very low force. Here you have a high force on this canine on the 2-3, and you don't see any paper mark there. Again, the paper doesn't stay sometimes under high pressure. It's sort of surrounded by low pressure, which is what you're seeing here. And next to it is a mark that is high force, but it's no darker than that lateral incisor mark, right? That's actually lighter than that lateral incisor mark, right? And this is an interesting area, the mesial of this premolar, which is actually a supportive implant that's under overload. That's why there's an implant warning. The paper marks are really indiscriminate, and yet the mesiolingual area near the marginal ridge is very high force. And this is the question for you. How would you know that? How would you know which ones matter? This doesn't matter. This matters. You can't know. Ink spots don't tell you that information, and interpreting them becomes hit or miss. So by using T-scan data, the destructive forces are detected at the delivery, and then complicating occlusal force issues are treated at the insertion, rather than being allowed to fester in the case and either cause the patient to have trouble with comfort, or things potentially start to break or come loose. So let me show you how this is done. This is a patient who had sleep apnea, and he was sent to me after the sleep apnea with this appliance, which was holding his vertical open for his airway and his jaw position. And the treating doctor wanted to couple his occlusion at that same vertical. So we use the appliance as a guide to prep the teeth and to design the occlusion. And that's why there's a piece of it missing here. I'm going to prep these teeth and provisionalize. We make veneer preps because there's no need to full cover this case. And then we install these ceramic veneers, full coverage crowns in the back, adhesive dentistry. And this is the day of delivery. And you see the case looks fairly well interdigitated. This is the before and after slide that we see in many presentations, but there's a lot of information missing here. This picture is actually an illusion, right? The illusion is that the occlusion is good because it all sort of touches and looks like it's a good result, right? Well, when you put the T-scan in there, you find out that it's not a good result, right? There's 3 places holding up the case, and there's no high force. There's no pinks or reds or oranges, because the patient, it can't really fit their teeth together. They're being stopped by 3 places. And you can see that here in this recording. And the left side is actually early to the right side. So this area, the center of force, actually starts on the left canine. You can see that right here. So there's a timing imbalance as well as a force imbalance, and 3 places are stopping the patient from interdigitating. And if I go back, you can't see any of that in this picture, right? And that's the illusion. That's what's missing, right? So this picture is really not telling the truth. This picture is telling the truth. And so what you do with this information is you map it again to the articulating paper marks, right? And then you know which places to adjust. So, you basically work out the problem contacts using T-scan data to guide you. And you make an adjustment set, and then you re-record. So if we go forward a little, this is after 4 corrective adjustments, and we'll see what the data shows. And again, the left side corner, despite making these adjustments, is still too early. You see the center of force, it still starts over there, right? So I still have a time problem here, and I still have a lack of really good right side interdigitation. And although the center of force comes to the middle, the timing trumps force because it's too early in this area, which is going to be problematic. This area is always going to be struck too hard. So again, we map it. And notice that this arch has only 1 premolar, and we've customized the arch, which is you can do with the T-scan. We've taken out one of the premolars, so we jump from the 2.3 to the 2.5. Now, I want to show you this area because it's actually very telling. These marks are virtually the same color. This one is a little bigger, this one is a little smaller, but in terms of their mark intensity, they're virtually the same. And the question becomes, how would you know which one to adjust when looking at them? And of course, that's a very difficult thing to do. But the T-scan shows clearly that the marginal ridge contact is much more forceful. That's the yellow contact. And the central fossa contact is very low force. And that really matters to you. And you face that same problem over here. Here you see the higher force on the right side is on the palatal cusp of the first molar. It really didn't mark. But if you look at the lower forces in the canine area, they mark better. So again, this is very misleading information that needs clarification for you to have control over how you manage your cases. So if we, after 5 adjustments, we now see the center of force starting more in the anterior and traveling virtually straight posterior. We have better balance. There's still some things that could be improved. And of course, we do the same thing. We map the highest force, the fast rising forces. And again, you see the highest force is barely marking. And this could be due to the materials, it could be due to the pressure, and yet nearby you have darker marks. Like look at this lateral incisor, that's a dark mark, but it's actually a low force contact that's in here. You can see that here on the 1-2, right? And so this is your problem every day. How do you know which marks to treat? How do you know which marks to leave alone? The T-scan helps you with that in one good recording. So when you get to the end, you have the center of force tracking towards the middle, and you have low forces throughout that rise simultaneously. And you don't see any pinks and reds and oranges, right? You see only low forces. This is how you want to release the patient, right? So you have metrics and values and force levels to go by, right? And from here, we would go on to do the excursions. So that was the day of delivery in 2012. Now, here's the case in 2017. And of course, this picture doesn't tell us much, but the case is intact. There's been very little breakdown, which is great. And what does the T-scan data look like in 2017? Well, it looks virtually the same, which is very important for you to understand that how the case leaves the door is how it's going to be. And so if it isn't set up well, it's going to destroy itself, right? And here it's been very preservational. Now, why did I make this recording 5 years later? Because we do something called prosthodontic recall, which is where when the patient comes in for their hygiene recall, we scan them and check their occlusion. And then I can go in and adjust these 2 places and make the case, again, low force throughout, and that preserves the restoration. So he's had a number of touch-ups over these 5 years in order to preserve the restoration, and that's why it stays intact. So it's very important that you use the T-scan not only to diagnose and treat, but also in the follow-up, because then you can manage the case. Just take a little off this contact, a little off this contact, and the case is preserved. So we talked about delivery. Let's talk about complications, how we control complications. So to control complications, you need to really understand the specific problem, and that you make a recording that then matches up to that problem. So it's very important to ask the patient, does their bite discomfort occur when they're biting down on their teeth, chewing, or clenching and grinding? And that answer dictates what recording you make. So if it's a biting down problem, like they say something like, all I have to do is bite down and it hurts my tooth, then we use a closure recording or a multiple bite recording where they bite down a few times. If it's during chewing that they have a problem, like they say, no, I can bite on the tooth, but when I chew, it really gives me a sharp pain, or I run into something, it feels like there's something in the way, then we use an excursive movement recording. You can also have them chew on the sensor if you want, but within excursive movements are all of the chewing motions. So it's easier to use excursive movement recordings. And if they say, well, I can bite and I can chew, but if I grind on the tooth, if I just sort of move my teeth back and forth, I can feel this problem contact, then you make a clenching and grinding recording. And these are very important things to understand. And as someone who if you want to get involved with the T-scan, we teach you how to learn to record these specific actions. So this is a typical biting down occlusal complication. This patient had a crown made on the 2.5, second premolar on the left, and next day he couldn't bite on his 2.3 and without it hurting him. And he went back to the dentist over a 4 or 5 month period many times, and the dentist was unable to resolve the difficulty. He even went as far as taking out the crown and making it temporary on the 2.5, and that didn't resolve the problem. And so the dentist was sent to me, the patient was sent to me, and the dentist told him, go see Dr. Kerstein. He has a computer. He may be able to figure it out. Well, I was able to figure it out in one T-scan recording. But before I show you the recording, this is what I saw with articulating paper. This very small contact on the mesial of the 2.3. And this was the mark that the dentist was seeing for 4 or 5 months. But when you look at markings, it doesn't give you anything quantifiable to work with. But the T-scan, you've already seen this movie, it actually isolated the problem contact right away. And there it is, this fast rising canine contact. There are other problems in the case, as I pointed out earlier, too much force on the left side and a late rising contact on the right side. But the main problem the patient was really struggling with was this fast rising force on the 2.3. And it's very visible. It took one recording to fix, to find. And the patient was amazed that I could detect the problem so quickly when he had many visits where it wasn't being dealt with. So then the process, as I just showed you, is to map the data to the T-scan data to the contacts, and that's what we're doing here. And this is a process of setting up the T-scan arch to match the patient, which is a very important aspect of being able to do this. And then again, this is a very small paper mark. So for my own purposes, I took out a thicker set of articulating paper, something about 60 microns thick, to see if I would get a different mark. And what I got was a lot of false positive nearby, but the same mark. And yet on the anterior teeth, there are very large marks, and you see they're all low force. And this is your problem, our problem in dentistry every day, every patient. What do the marks mean? What is their force profile? And how can I understand them? So I make intelligent choices about what to treat. It was very easy to know that this was the contact to treat, right? It's the high force contact. The others around it are all low force, and it rose too fast. So as soon as he brought his teeth together, he was, hurting his canine with this very high force contact. So this was the pre-op, which you already saw. And in the same day, this was the end result. And you see the uniformity and the simultaneity and the lack of rapidly rising high force. There's still a little bit on the right side, and I can go in and just take a little away from that. But this was resolved in one day. And the patient's comment was, I don't understand it. Why didn't my dentist have one of these T-scans? I mean, you figured it out in one day, right? And I've been going to him for months, right? That's the issue. The data allowed me to find the problem. And without the data, the problem went on and persisted. So here's a complication that's an implant complication that involved both closure and excursions. And one of the nice things about the T-scan software that I mentioned earlier is it has the implant warning feature, which tells you that your implants are being overloaded and you better manage the forces there. So this patient I met, it's just to show you how common these problems really are and how frequent they occur in dental practice. I met this patient at a dinner party, and he asked me what I do for a living, and I gave him my professional tagline. I said, I train dentists to use technology that improves bite outcomes. And he said, well, I have a bad bite outcome. I have 3 implants that were put in, and ever since they put in, my bite has been thrown off. And so he came to my office for a consultation and evaluation. And he has an implant here on tooth number, this would be the 1.7. This would be the 1.5. He has an implant, and I think one on the other side. And the problem one is on the 1.7. And you can see that here. There are 2 other implants, the 2.6 and the 1.5, and they don't have a warning, right? And this was the articulating paper marking. So there's obviously a lot of contact on the 1.7 implant. But what does it look like with the T-scan? So the center of force, which is, again, moves towards high forces, you see it goes right towards the 1.7 implant. And there's extreme overload there. There's not only one high force, there's also a collected area of moderate force. And this is the nature of the implants. The rigidity concentrates stress. There's a physical principle known as the least mobile element. The least mobile element in any system concentrates all the stress. And so, implants concentrate stress. The other 2 implants were managed reasonably. They have low forces on them. But you can see the center of force travels right to where the stress is being concentrated. And it wasn't only in closure, it was also in the excursion. So here, this part of the movie is the excursion, and the patient is going to go to the right, and you see how the center of force goes right towards the implant. It even has a moment in time where it actually points directly at the implant. And so this case involved reducing both closure forces and excursive forces. So here I've done my bite adjusting on the crown. I actually exposed metal. And, we tell the patients if we're going to adjust their bite and they have crowns that we might expose the metal in advance. They have to give us permission to do that. I've obviously reduced the amount of surface contact, but this doesn't mean it's good. Any one of these could still be high force. There's no way to know. The only way to know is to remeasure, right? So here's the closure component at completion of that first visit. And notice the implant 1.7 is not under warning anymore. And you see the center of force tracks towards the center of the arch rather than towards the implant, which is a huge improvement. And then you see how similar the forces are throughout. This looks like the other case, right? Low forces simultaneous all throughout the arch. That's your goal. Now in the excursion, the center of force tracks away from the implant towards the canine, which is ideal, right? So all of that was controlled by the T-scan data. And again, it took one appointment to straighten it out. And he had many appointments where it didn't get straightened out. And so this is the nature of these problems. They don't go away just because the patient comes back and we remark the teeth and try to adjust. We need some way to know that we've improved it. And T-scan is a great diagnostic tool, a great treatment tool, and a great metric to follow up and determine that you got the right result. Here's the last case I'll show you, a full mouth rehabilitation. This case is another example of how the dentistry was beautifully performed, but the outcome was not occlusally well designed. And the patient struggled with getting used to it and went back for, obviously a number of appointments. So here's the pre-op situation. There's a couple of implants on the lower left. And I believe there are some other implants in the case also. Here is the metal ceramic restoration. You can see the artistry of the restoration is beautiful. There's layering of the ceramic. There's a lot of internal characterization. The porcelain is beautiful. And here's the occlusion illusion. Again, this is the picture of the end result, saying, look how good the occlusion looks. Look how nice the case looks. But the occlusion you can't see this way, right? So let's see what it really looked like. Again, the implants, the least mobile elements, concentrate all the stress. And this is the mandibular arch. And the right side is coming together, but barely. And you can see, obviously, there's extreme overload in this area. But it wasn't only closure that was taking place, overload. This is the excursion to the left, and you're going to see this area slows down the excursion to the right. And you see how there's a sort of a choppy reduction in force there where it blocks the patient from easily moving to the right, even though the anterior guidance takes over. And the beauty of this kind of information is it's happening in fractions of seconds that you can never see with your eye. This is a time curve down here. And so the excursion begins here at C, and it takes him from about 4.3 seconds to about 4.7 or 8 seconds. So about 4/10 of a second to move to the right, to disclude, which is a good time, but in that time is a lot of posterior contact. So it's actually not a very good result. Now, the left excursion, if you look at the time curve, has these steps in it. And this is friction. And again, happening in 4.5 to 4.9, 4/10 of a second about. So watch the friction. That's the choppiness as he tries to go left, right? That is installed on the occlusal surfaces, and that was not detected at delivery. So all things have to be corrected here. The closure, overload, and the right and left excursions have to be corrected. So after we did some of the initial adjusting guided by the T-scan, I've changed to the upper arch to show you that there's a new implant under overload. And again, this is the beauty of the system, right? I made a set of corrections, and then I go back and use the T-scan to verify that it's good or not good. And sure enough, there's a new implant being overloaded on the upper right 4. That's not good, right? But how would I know that if I didn't have the T-scan? And it wasn't only overloaded in closure, it also was part of the excursion. Now watch what happens. This column is going to go up early in the excursion. The excursion starts right here, and you're going to see this go up for maybe 2/100ths of a second, something you could never see with your eye. Watch carefully. See, it's getting taller before it declines, right? Again, impossible to see that with your eye, right? The whole excursion was 6/10 of a second, right? So if you see the beginning of it, there's a force rise, and then there's a force decline. Incredible detail that you can get with the T-scan that you can never see with your eye. And so we need to correct that before we can send the patient home. So here's the final closure, and you see now there's no more implants under overload. You have the similar low force profile throughout. And in the left excursion, you see there's no more implant warnings also, and the center of force tracks anteriorly towards the canine, again, ideal. And this is how you manage the cases. This is how the case could have been delivered, which is really the important thing I want you to understand. You can use the T-scan at delivery. It saves you a lot of difficulty in the aftermath. And so this took an hour from 10:28 in the morning to 11:25 in the morning, and to get this result. And you can see the center of force preoperatively heads right towards the implants. Postoperatively, it heads towards the middle of the arch, which is ideal. So people will often say to me, well, I don't have an hour to adjust the occlusion. You know, I don't have that much time in my practice. So what happens then is you may not have the hour at delivery, but you're going to waste a lot of hours in the upcoming weeks and months seeing that patient again and again. So setting aside time to deliver the case with the T-scan allows you to minimize that problem. This is how the patient could have been sent home, right? That's what I want you to understand. Delivering the case well makes a huge difference in the aftermath, because this is an illusion, right? And this is the problem we face every day. The beautiful dentistry doesn't necessarily work occlusally because we install it with materials that don't really allow us to control the occlusal forces and the occlusal timing. Now, there are questions about other occlusal analysis systems that are being that have been introduced into the marketplace, which is a great thing because it's expanding the need for digital occlusion. It's showing there's a field that's growing, that there's new technologies. And so what's important for you to understand is neither of those technologies, OccluSense or Accura, were actually included in this wide-ranging occlusal indicator systematic review. And the reason for that is there's no research on them. There's no publications about them. There's no clinical use that's been tested on them. Whereas T-scan, over the last 37 years, has much scientific evidence that supports its use. And so these technologies are not valid or proven. And so although they may be less expensive, that doesn't mean that's going to help you chairside, because there are issues with using them that you haven't encountered yet. Because there's no published OccluSense, Accura, or Accura treatment research, showing these systems are accurate, reliable, that their sensor works well, that their data is reproducible. There's no way to know how well you can use them. And there's no clinical research that shows how you use their data to improve an occlusion. This kind of looks like T-Scan Acura, but again, it's not a T-Scan sensor. It's not made by TechScan. This doesn't look at all like T-Scan. And one of the most important differences is the arch is not segmented and there's no way to customize this arch. So the question becomes, where is this? On what tooth is this? On what cusp is this? Right? That's a real challenge when it comes to using something like this. The arch is indiscriminate, which means you won't know really what tooth you're dealing with. But because there's no research about how these work or what they actually do, a user of them won't understand how to use them in a safe and predictable way with their patients. Certainly not in a proven way because they're unproven. And that's the question is, what parts of this do you use to adjust a bite? Why is there a tall red and why is there a small red? I don't have those answers, right? I can't tell you that. But someone has to figure that out. And as of yet, that hasn't been figured out. So how you use them with patients hasn't been determined yet. And that means if you want to use them because they might be less expensive and you think you're using a T-scan, you're definitely not using a T-scan. It means that you're going to be on your own chair side trying to figure out what their data means. That's really not going to help you at the chair, right? You're going to have to sort of play around with it and say, well, if I make this adjustment, did the patient get better or did the patient get worse? That's not going to predictably help you at the chair side. A lot of research has to go into how these work before they can become useful and predictable. But the T-scan has published research in many proven treatment protocols in many fields of dental medicine. These are all the fields that are incorporated in this 3-volume handbook of T-scan research, right? There are studies on T-scan in all of these disciplines, which means as a user, you can learn to use it and apply it in many different ways. And there's research to back it up, and there's also clinical protocols for you to implement that are already tested and proven. And so once you learn how to use it, you can fix a lot of things in a lot of different fields. And again, one of the beauties of the T-scan, as I said, is you can incorporate an STL file, which really makes simplifying like where this contact is in the mouth. But even the T-scan arch is customizable. You can shrink it, size it, take out teeth, notate implants, put in edentulous areas, all kinds of things you can do to the T-scan arch that make it possible for you to locate exactly where the problem contacts are. And that is a really important thing I want you to understand. If you don't have a matched arch, you're going to be basically trying to figure out, what cusp is this contact on? And the T-scan software itself or merged with an STL file completely eliminates that issue. So the T-scan applies to all of these fields, right? I used it many times with partial dentures and complete denture installations. Post-orthodontic corrections, I showed you a case where the orthodontics wasn't ready to be debanded. And then, of course, once it is debanded, then you can optimize the occlusion with precision occlusal adjustments post-orthodontically. Implants, obviously, with the problems we're seeing with breakage and fracture and patient difficult occlusal adaptation, there's a huge need for T-scan and implants. Overdentures, complete dentures, partial dentures work extremely well with the T-scan. Adhesive dentistry, a crown and bridge. These are things that you're doing daily. The applications are many and the protocols are already proven. So you're basically have a tool that can help you in any discipline that you practice in. And from a practice management standpoint, that translates into increased revenues, basically because you reduce problems like this, fractured implants. But the most important reduction comes from reducing those costly post-insertion adjustment visits where you can't do the crown in room number 1 because you have to see Mrs. Smith again in room number 3 for the 5th time or the 7th time because she's not comfortable with the crowns that were placed a few weeks back. Right? And that's a huge problem that pervades dentistry. It's something that I've seen all over the world. And so by getting improved outcomes, you lessen this post-insertion adjustment problem, and you get improved outcomes because you're using actionable force and timing data. Remember, scanning technology is just taking pictures of teeth. It's not controlling the occlusion for you. You can only do that if you measure between the teeth. And the T-scan is the only proven, validated technology that does that. And when you get improved outcomes, you have happier patients who readily adapt to their new teeth in far less time, like this young lady.
So I kind of assumed that I would feel a difference in a few weeks or a few months or something as the muscles start to relax.
Yes.
But I didn't anticipate feeling something immediately. And I can already tell there's a significant difference when I'm biting down, a lot less pressure, and it's pretty miraculous that you can feel it immediately. It's definitely not at all what I was expecting.
So thank you for your time and your attention. I appreciate you meeting up with us today to learn about the T-scan technology. I certainly hope I was able to show you the value of measuring the occlusion, and that measured digital occlusion is a major advance for the patient and your practice over traditional occlusion. And I want to thank TechScan for sponsoring the lecture, and I look forward to taking some questions that you all have.
Perfect. Thank you so much, Dr. Kerstein. We appreciate your expertise and your information as always. We did cover a lot of information, so I do want to take some time to address some audience questions. There were a few common themes that come up, and you did sort of touch on this. The first question is around, can sensors be used for measuring forces on teeth during chewing with food? Or how do you recommend chewing recordings, I guess?
Very good question. I can't answer that as if I ever put food in someone's mouth and had them chew, but I did record chewing, having them chew on the sensor and record that, and that works extremely well. Although I think you could probably try putting a bolus of gum. If it didn't stick to the sensor, you might be able to chew on that, because gum doesn't get destroyed, and it just gets manipulated. And so you could try that, but I can't honestly answer that with my own experience. But I did do many examples of chewing on the sensor, and the patients are able to chew on the sensor, and you gather data very nicely.
Okay, great. Next one here is, what is the recall? What is your recall protocol for full mouth restorations?
So that's a very good question also. With respect to hygiene recall, it would be either 3 or 6 months they would be put on a plan in order to manage their degree of periodontal breakdown that they came in with. If they were an advanced, periodontal patient that needed periodontal prosthesis, they would be on a regular recall, both with myself and with the periodontist, where they would go back and forth between both offices. Typically, large cases would be recalled at 6 months, and at each recall, we would scan them with the T-scan to preserve the restoration, as I showed an example of that. And that was very helpful. So it's case by case, but using the T-scan at prosthodontic recall was a great advantage, because there were many times I would find a rapidly rising force that evolved. One of the reasons this occurs, and that's why this is such a good question, is a lot of the cases are made as a one-piece provisional, 14 units in one piece, but then they get turned into single 14 units. And over time, those teeth move, and they move in response to the occlusion. And even though the occlusion might be well managed at the delivery, over a series of months and years, those teeth will adopt a new position in the PDL. Less so with the implants, but certainly with the natural teeth. And so adjusting the bite with minor improvements periodically helped compensate for that tooth movement that wasn't present at the deliveries. And with the implant cases, also very important to keep checking the bite, because if they oppose natural teeth, the natural teeth actually move away and get pushed backwards. And some of you or pushed down, I guess is a better word. Some of you may have seen that. You put in a couple of implant crowns on one arch, and 6 months later, there's a food trap on the opposing arch, right? And why did that happen? Well, it's because the opposing teeth were moved. And it's very interesting research that looks at that. Baylor University found that single implant crowns that oppose natural teeth induced bone loss in many, many teeth that opposed single implant crowns. So it's very important to retouch those cases if you can at each recall, and the T-scan is ideal for that.
Perfect, thank you. Is there any case that you can't use T-scan on?
Theoretically, no. Anywhere you would use traditional occlusal indicators is where you would want to use the T-scan. So, I would say if you're doing buccal composites, on an abfracted tooth, even though there's no occlusal treatment being rendered, in other words, you're not treating the occlusion. The reason there's an abfraction is because there's an occlusal overload. So yes, any situation where there's evidence of occlusal breakdown or prosthetic intervention or concern over the occlusion, you absolutely can use the T-scan.
Perfect. So the next one here is around adjusting occlusal splints. So do you have experience in using T-scan for adjusting occlusal splints or night guards? And do you have any technical suggestions specific for adjusting splints using T-scan?
Well, that's also a very good question. So yes, I have a lot of experience adjusting splints. Not that I made that many splints. One of the great things about using T-scan is you don't need to rely on that many splints. But having said that, when splints were necessary, you can visualize this in your own head. If the splint is installed with 65% left and 35% right, that left TM joint is not going to be happy with that, and that really slows down your adaptation, right? And so a typical splint adjustment is just a bunch of paper marks, spread around the arch, has nothing to do with whether it's balanced or simultaneous. So it's a really important advantage to use the T-scan when delivering splints. And people who do neuromuscular dentistry, for example, with the T-scan find it really speeds up the patient phase one, where they're trying to get their person out of the splint into the next stage of treatment. They find someone like Dr. Curtis Westerson. He could address this because he does a lot of neuromuscular dentistry, but having worked with him for many years and trained him on the T-scan, how to use it with splints, he has found that his phase one is much more improved than prior to using the T-scan. So there's a great advantage of using T-scan with splints.
Okay, great. There was a few common questions around training for T-scan and how hard it is to learn the T-scan. So maybe you could just address that not necessarily how hard, I guess people said, but how much time does it take to become proficient with T-scan?
Well, with any technology that you would want to implement, there certainly is a learning curve, and that T-scan has TechScan, the company, has many resources to help you. There are courses, there are online training devices, meaning videos and courses that are through the company. There's one-on-one individual training, which I do, where people ask me to come to their office and teach them chairside. So the possibilities to train are many, and the company is very dedicated to educating its users. In terms of how fast you become competent really depends on you, because it's kind of like, you can take a golf lesson, for example, but if you don't go to the driving range and practice, you don't get any better. You had the lesson, you know what's wrong, but you don't get better, right? So you have
to use it. Yeah.
You have to take the principles that you're taught and then go back to the patients and make recordings and understand that they're good recordings, they're not so good recordings, and how to improve that. That's probably the most important aspect, is to become a good recorder. And once you are good at recording, then you can really make a huge difference in understanding the data. And from there, you can then adjust with intelligence. So I would say the learning curve, although real, is really depends on your willingness to put the T-scan into your hand and use it, and take it out of the off the counter and record on it. You can record on staff at the end of the day to learn. You can record on your patients, people who come in for recall. You can check their bites, and that really is what develops your skill. Using it, once you have some knowledge, which the company obviously helps you get started. And the training that you have online actually, which is introductory training, really gets you going from the beginning, because that goal is to be able to get you recording, to get you start recording. So from day one, you can get off the ground, but then it depends on you, the doctor, to get in there and use it.
Okay, great. There was a number of questions that came up on price, and maybe I will just address that quickly to give people a little bit of additional information. So most of the cases that Dr. Kerstein was showing in his presentation were using our T-Scan Novus product. We actually have two products, T-Scan Novus and an entry-level T-Scan Novus Core. So depending on the type of practice you have, if you're just getting started, T-Scan Novus Core might be for you. If you're doing more comprehensive dentistry, more advanced dentistry, you're going to want the features that are in T-Scan Novus. So the great thing is that if you start even with T-Scan Novus Core, there's a very clear upgrade path to T-Scan Novus. And the best thing to do is to reach out to us at info@techscan.com, and we can connect you in with your local distributor if you're not already in touch with them, and our international sales manager as well could help answer any questions that you might have specific to price. So hopefully that addresses the price question. We do have a few other questions here. Maybe what we'll do is, I think in the essence of time, it's late for many of the people that are in attendance today. So I think what we'll do is end the questions, and we will reply to people. We'll have Dr. Kerstein specifically reply to your questions so that you can get those answered. But it is getting late for most of the people that are on, even though the sun just came up here in the Boston area. We thank you so much, Dr. Kerstein, for your time and your energy in this presentation. We encourage you to reach out to us directly at, again, info@techscan.com. And we thank you again, and please enjoy the rest of your day or evening. Thanks for joining us.
Yes, thank you all for your time and attendance.